Now, most of those patients have risk factors. Number one, they didn't get regular testing. Part of the reason is socioeconomic. Poor people, bad neighborhoods, bad healthcare access, no health insurance. They're the ones not getting it. If we put even a half effort into increasing capital profit clearance and screening, we could have that. We could eliminate 2,000 deaths just by putting a small amount of money into those community clinics. Okay? They also have risk factors. Usually co-infection with HIV or chlamydia. There's smokers, which add a risk factor. Prolonged use of birth control also adds to the risk. So they're not just people out the back end, they're very narrow group of people. So the chances of your child getting non-cervical cancer are astronomically small, even when they reach into the 60s. Okay? So let's talk about how communicable it is. I think that people will realize it's not. Unless you have a sex with the person sitting beside you or somewhere over here, something's going on that I don't see, you're not going to get the disease from that person. Okay, so as far as being highly communicable, it's not. So it fails the first two tests, the reason to have a mandated vaccine. Okay, let's talk about alternative treatment. Taxing is over 91% effective in preventing cervical cancer. The reason it's effective is that precancerous lesions, which you call cervical intraepithelial neoplasm type 2 and 3, and also carcinoma and adenocarcinoma lesions. It takes years. From that lesion appears, it takes anywhere from 5 to 10 years to develop cervical cancer. So you have plenty of time to catch that on a pap smear. If you get a pap smear the first time, you've got a second shot at it. And then you've got a third, and then a fourth. That's why it's crucial to get those pap smears. And guess what? If you get the vaccine, you still need to get those pap smears because no matter how effective, what they're saying is 70% effective, it will never be better than pap smears. As a matter of fact, we did a little hearing about it. Diane Hospital was the lead researcher for phase 2, phase 3 studies, bringing this drug to market, saying that the combination of Gardasil, which is what she mainly worked on, and pap smears together would not have any change in total population deaths at the end of the road. In other words, it would still be 4,000. Not have an impact on the total population. Maybe on an individual basis, but not a big number. Okay? Now, as far as alternative therapy, there's a nice article in the New England Journal of Medicine that looked at condoms. And they found that, now to read the findings, if you use the condom 100%, so it says, in women reporting 100% condom use prior to their partner, no, I repeat, no, cervical squamous intraepithelial lesions were detected in 30 patients years of this, whereas 14 incident lesions were detected during 97 cases in a woman's partners who did not use condoms. Almost 100% reduction. Not only in 4 disease, but the other 15 oncogenic cancer causes, plus the 700 generally workplace. Condoms are a very viable alternative. We should be highly emphasizing that to all individuals. Okay, so 2 extremely good alternatives. Also, mentioned here that the lesions often get better. That's absolutely true. Precancerous lesions, after 1 year, 70% go away. After 2 years, 95% will disappear. That leaves less than 5% that potentially go on to cause cancer. So just because you have a lesion doesn't mean it's going to go anywhere. A lot of women get it and not treated, it goes away. Gardasil was originally designed for third world countries where they're not getting pap smears. If you're not getting pap smears, getting that vaccine could make a difference. Even though it's not as good as a pap smear, if you don't have access to it, it could at least reduce you and help you out a little bit. And that is the reason.
What is your first year that what age is the youngest age that you would recommend?
Well, I think the pap smear stops at 21, something like 18. I'm not going to tell, so I'm not doing the exact year. It's around 18. It's sexually active.
There are people that are sexually active.
Right. But they're not going to die because there's no way that these will develop before they're 21. That would be dangerous. They would discover that before it would go on carcinoma, cervical cancer. It takes 5 to 10 years for that to develop. Just because you have HPV, most people in their life, most will have HPV infection. So you probably had it, other people had it. Asymptomatic, it goes away, and you have a new one. I mean, maybe one or two.
How do you medical affairs who say you granted on behalf of your patients based on...
No, because I don't think vaccination, so that's not my opinion.
You would still be consulted.
Okay. Let me put it this way. This is the fact out of this, that I had to do PhD now. So this is from her to you. I think I did it.
Dr. Alexander Scott?
It would be, the one that went around doing the HPV symposium. But she said there was a question of that. If a patient has a seizure, this is, I think I had to really cover all this thing. If you go and get the first hospital injection, you have a grand mal seizure, that is epilepsy. You're rushing to the hospital to put on a single bottle of salt to find it stops. Matter of fact, it's so bad, they put on that program and you stay on it. When you're up to your next vaccination, that's not common for medical attention. I cannot give you a medical attention procedure. It's not common. The only medical attention you can get are like giving the ray, you can allergies to vaccines like that.
A physician, it doesn't say why the physician has to get medical attention.
That's the head of the DPH. That's who told me. That's where I got it, from Vermont. So I would check with her. But that is, you just can't really give a medical attention. It's not a DPH, from my understanding. But again, that's the head of the DPH. All right. So alternate treatments we talked about. So let's talk about the catheter.
People do one, but there are people that don't specify.
Okay. So I'm going to quick because I'm going through very quick.
And the reason I have is, correct me if I'm wrong, but there are no other entities that are...
That I'm not sure about. I don't know.
I could be wrong, but there is, do you have any... Why do there are no other entities?
Oh, because we work. And then we work hard. I have to say that patients come in. I think we can meet with people like Dr. Korsanowski, we try to get Dr. Alex Gorski, Dr. Joe Pilato, Dr. Eric Dominguez, Dr. Angela Howard, there's Dr. over there, Mark Adams, who else is there? Dr. Larry Patel, Dr. Christopher Johnson from internal medicine. There's plenty of doctors that think exactly like that. It's very good. I didn't look to be out of the big spot. By the time I sat down, it was 4 o'clock. Very good. And I had to cancel. I have to leave. And I booked 3 months in advance. Those people have to wait a long time. So it's not easy positions to get in. And, you know, it's the way it is. It's the people that have a real interest.
I know. We've been many months and we've had some money to a lot of doctors.
Right. Now, I can tell you, say, well, why don't I see the album? I don't know that. I'm not a gynecologist. I'm not a pediatrician. Well, I can tell you, I can read literature as well as anyone. And I come to the thing with an open mind. I don't have any baggage, any preconceived ideas. I look at the data, and I go where it is. That's evidence-based medicine. I live by it. I decide everything for my patients based on best evidence. Not just any evidence, but the best evidence. Attachment. My wife has a degree in statistical analysis. She teaches me a lot about how to break these down and how to show where they say 98 efficacy, meaning break it down, and we break it down, and we really find out it's only 17% efficacy, which is an article about gospel, I think it's in the handout, where they break it down for you, and $60 for the given support. And I have it in the German medical article that they refer to, and that is a good source for that. So let's talk about that. Let's see what the article says. I mean, I have no opinion. I just read what the literature says. All right, this is from the Journal of American Journal of Public Health. This is the journal that has the Department of Health Review. Okay, this is the name of this article is Who Profits from Uncritical Acceptance of Biased Estimates of Vaccine Efficacy and Safety. Okay? And it goes, the claim that classical vaccination will result in approximately 70% reduction of cervical cancer is made despite the fact that the clinical trial data have not demonstrated to date that the vaccine has actually prevented a single case of cervical cancer, let alone cervical cancer death. And that's true, because Merck decided not to study cancer because it takes 20, 30 years. So they're looking at surrogate markers, pre-lesions. nor that the current overly optimistic surrogate marker-based extrapolation are justified. Okay? So what you're saying is, it's never been shown to stop cancer. You're correct. And if you were to push that into the case, what's the reduction that's actually been seen in cervical cancer from the gospel vaccine? You have to say zero. Shouldn't that know about 70% surrogate marker?
What research do you think the department of health used to arrive at?
They're looking at the surrogate marker now. In other words, they're saying, let me put it in real common terms, so I think you don't have to see it. There are 15 cancer-causing HPV viruses. The article covers 2 of them. It has 4 HPVs, but the main 2, 16 and 18, is what it covers. Okay? And they say that in studies, we've seen a 70% reduction in those 2 particular cancer lesions. Okay? So they say that means we're going to have a 70% reduction in the cancer. Let me explain to you in a simple way. You have a breast tumor, very well circumscribed in your breast, and we're going to do a lumpectomy and take that tumor out, and add it to the lymph nodes, and we're going to cure it. So you go to surgery, you wake up, and you're in your hospital, and the doctor comes over and says, well, you know, we were running short on time, so we only took out a quarter of the tumor. And we took out the part of the worst part of the tumor, and then we sewed it out. You're cured. After the astonished face comes off the person, what do you do with the doctor? If they don't take the rest of that tumor out, they're dead. So here, they're stopping two viruses from going, and they think, well, that's been cured. But what happens to all these other cancer-causing factors? We're going to get into that later, because what can happen is, even though they weren't prominent and more aggressive, once they're away, you don't know what these other viruses can do. Think if you did it. It's in your gut, and normally you think it was the number.
That's actually what we see out, okay? Okay. We had some vaccinations for 15 pre-cancer conditions. That were proven, let's just say they were proven, okay? Proven so that all of you all, as close to unanimous as you could get.
Sure.
And you had a vaccine for 2 of them, you would think that was a bad idea because it didn't help the other 13?
First of all, you're making up the wrong assumption. You're making the assumption that all the cancers are just the HPV viruses. That's not the case. There are other causes for cervical cancer.
But it's not the question I asked.
Is I think you cover all 15, but
no, you could only cover 2 out of 15 cancers, but unrelated to HPV. Would you recommend not? Doing that because there's only 2 out of 15?
I'm not sure what you're saying. Because I think 2 cancer, I think lung cancer is very high and cover those.
Right, so you wouldn't give a vaccine that prevented lung cancer because it didn't cover kidney cancer?
I wouldn't force someone to say.
Right.
I wouldn't force that. There's so many factors that go into it.
So would you recommend?
I would have to look at the data. I mean, it all comes down to the numbers. What's the efficacy? What's the side effect profile? What's the disease profile? What percentage of due to that vaccine? Because remember, there's something called original antigen, and I don't want to get into technicality. But original,
that's not technicality. Consider that everybody has 1%.
All right. I'll go through this quick. And, I can do it later. I know that. So, the efficacy shots. Let's talk about some of the side effects, and I'll bring it with the I'm just trying to think about it.
We haven't heard about that.
All right, so this is very good. You have this model with you have this. Well, these are the scientific numbers. It's not,
We've heard films like this before, and we've heard about side effects.
Well, this is, I'm not listening to that. I'm just making 1%. This is from the journal. Okay, so that's scientific way, not from math and great proof. And this is again from the American Journal of Pharmacy. Again, with all other vaccines, optimal knowledge associated with greater than 60% of all serious adverse drug reactions, including 63% of all deaths and 81% cases of permanent disability in females under the 30s. In context, while females in the cities who have a near-zero risk of dying from cervical cancer, they have cases of risk of dying permanently disabling condition from vaccine that has not been associated with cancer. So, let me just move on. All right, so you heard about the side effects, and this article is listed, and I don't know.
That's something that we can convert to.
You have.
So we have to.
I did. Yeah, and I think that this is called, universal vaccine policy and evidence based medicine.
It's fair to everybody, if you present a prescriptive document with the information, you do not have to.
I won't read this. This is a subject. Now, this one I didn't read, and this is a crucial option, the one I'm going to really, just frankly, briefly, this is a 29-page submission from Merck.
You don't read all 29.
And it's crucial, because this subject is from Merck, their Merck, not mine. This is the vaccine-related biological product advisory committee submission for the vaccine. Okay, it's all the steps to get there. And
So any drug
we'll have to
presented to a physician would have the same report, right?
Well, no physician reads this. Trust me. I have this, so I'm reading it. It's a lot of studies, a lot of stuff. But I'm going to really like to read.
We at the Health and Human Services Committee,
But
our office presented to the doctors who read this data. So I think that's inappropriate.
I'm just going to do what you said.
That we have doctors that we consider responsible on both sides of any issue to present similar data on other subject matter. So to say that no doctor reads the data is not our
When I say most doctors don't, your pediatrician in the office has not read it.
I mean, we have physicians that come in here to present similar data.
Well, if they ever get subject matter, if they ever get that, I cannot be on the meeting for spouse or whatever the name is. Really, as a physician, I read it, it's astounding. And I'll just read it. It's what's on the front. Take a second. This is some studies about coronary endpoint analysis of notes. This is from Merck. There were two important concerns that were identified in the report of the efficacy review of this. One was the potential for doctors to enhance disease among the subgroup of subjects who had evidence of system infection with vaccine-relevant HPV type at baseline. In other words, this is the astounding top. If you have HPV infection already, but vaccine will not clear that HPV, but if it does, this is study 313 at the hospital. It showed an efficacy of minus 44.6%. What that means is, with their story of market extrapolation, they're saying in this article, in this study, that if you get the HPV vaccination, you have an HPV infection, your chances of cervical cancer went up 44%. That is astounding. Anything that would have that in it. And BPH does not advise that HPV test for anything, which I find astounding.
I wanted to know the differences about what you know that you're down to 2 centers.
Okay.
So, and I'm looking at it, and I thought that they would want to be presented to a many centers response.
But I can very quickly, I think especially if you wanted to put that in, I don't have any more studies to do in the content. And so I told you that it doesn't fit the body.
Doctor, I think we have given a adequate testimony, and it's very much appreciative of the activity you guys are doing.
One last thing about the conscientious objection, right? This will be the last one. This is really important. Because you're talking about why conscientious objection to medical attention. Medical attention is very specific to that. It's insulin, allergy, and stuff. This is a article from the Journal of Experimental Therapeutics and Oncology. It's called Quantifying the Possible Cross-Reactivity Risk of an HPV-16 Vaccine. What it tells you in this article is that the number of biomasses in neural patients may be occurring if 5 autoimmune cross-reactions in what's called a HPV-16-based vaccination almost unavoidable. In other words, you will develop autoimmune disorders. This is false. But autoimmune disorders account for a lot of that.
What's that actually the conscience?
Well, this is the follow-up of that. And what they found was that, and I'll just put in this and I'm done. I'll just end it here, because I think this covers everything. They looked at, in fine questionnaire, people that were damaged from the vaccine, and they found the gathering reflected a 2 to 4-fold increase in occurrence type and severity of symptoms, which were listed. So what they found was, and this is why conscientious objection is important, is that one practical consequence of these findings might be that those who choose to receive scholarship should be informed that if they experience certain adverse post-injection symptoms, it might be an indication that they should abort the inoculation protocol. Under mandated vaccination law, they can. If If they have a seizure, they still get it. If they feel fatigued, they get that shot. There's no opt-out for the doctor. As a physician, I've never given a medicine in my life where I was forced to give it. In 30 years of medicine, I've never forced a patient to get a treatment I decided to give. We came to a conclusion. If that patient had a seizure from any medicine I gave, I would never give that medicine to that patient. I would never give a medicine to raise that. But I have to legally stand behind my action. I can be sued, and I can do it if I do it again. I have to know the risk. I have to know the literature. For the vaccine, I'll push you out the door if you have a seizure, and you go talk to the federal government. That's no way for a physician to terrorize them. Right. I need to have the ability to say, no, I know that doesn't fit the strict criteria for medical intervention, but I continue to be able to opt out and make it fun. So there it is. So there's a lot of thought. I think it's one hour that I can get to the point. And then hopefully you'll give it consideration. I do support you still as a physician.
As I was saying, 2002 vaccine, you started off by saying you don't do that.
I don't do that, but I'm not some physician, and I read the literature, and I don't have to fire, and that's huge. There's no unrealistic enthusiasm about it. It's based on evidence. And when you ignore evidence-based medicine in favor of enthusiasm, it's something like bias, where we were told by a center that 40,000 people died and gave an extension to look at it. By the time they pulled it, 18,000 deaths and 200,000 to 300,000 strokes and heart attacks. I really like that, and I got to use the literature big time. We're not trying to